age with BVD, for instance. Okay, now we're being recorded. There's really no human clinical studies published to date in pancreatic cancer, and I wonder why my button doesn't work to move the slides. Okay, so our first case is JR, and JR has no problem sharing his information with the healthcare professionals that I talk to about him and share his labs. He is a 78-year-old white male, retired home builder. I learned the difference between a contractor and a home builder talking to him, because they're involved with every aspect of building the custom home. He's a Jehovah's Witness, never drank or smoked. He came to me with the complaint of wanting to use, actually through a family friend that I had success with another one of that individual's friends in treating early onset cancer. He wanted to, he was sent home. He was told, there's nothing else that we can do for you, so get your stuff in order. But the oncologist that's seeing him is hopeful that cannabis will help him and has been supportive in drawing labs and doing anything that he actually needs. But as we'll find out, he doesn't actually need a whole lot or ask for. He's got a significant past medical history of type 2 diabetes, diagnosed in '95, hyperlipidemia in 2005 and 13. He got a diagnosis of prostate cancer, and on 7/20, pancreatic cancer following a biopsy on 9/27 of last year. His height and weight has been relatively consistent. He doesn't have any food or medication allergies. He's been married for 59 years, has 2 children, and lives with his daughter and her husband in a fairly large home in outside of Denver, Colorado, and he does have an active lifestyle. The medication that he was on in January when I first engaged with him was insulin, metformin, atorvastatin for his hyperlipidemia, the rest of the meds you guys are aware of. Hello? Oh, please silence or mute your microphone if you're not engaged in asking questions, please. Lupron Depot, Q3 months, and what's interesting is he decided not to continue that therapy and see what's happening. He's on 2 liters of O2 a night using CPAP, and he was on a number of OTC vitamins and minerals. So for those that like to see the real detail, you should be able to read this, but this is his biopsy of the prostate, both the left and right core, and it describes his Gleason score and all of that. And this is his, wait. Did that change? Yes. And this is his biopsy on his pancreas. And it showed an invasive pancreatic adenocarcinoma that it had extensive chronic pancreatitis forming discrete nodules. It had a grade of 2 out of 3, and it extended into the pancreatic fat. And and so its presentation isn't common, and that may be why we're experiencing what he's experiencing today. Some of his lab tests, this one showing a C19-9 marker, and this is showing a history from 7/25/19 to April 21 of this year. It looked like it was doubling from September 30th up every 2 months up to this last test, which I'll show you the test results later, but on 6/8, which was earlier this month, it climbed up to 43,503 from a 26,186 number previously. This is his PSA. He was on Lupron again back in 2020 or 2020, and you notice it's kind of been flat during Lupron therapy, except for a little bump in April of 2020, where it was hovering around the high 1s or 2s, and after he stopped his quarterly Lupron injection, which would have been earlier in late 2020. In January, it started going up, and then by March, it was 7.87, and as of the first part of 6/8 of this month, it had gone up to 15.58. This is his comprehensive metabolic panel. Besides the blood sugar, you know, and a slight, there's really nothing exciting about this. His WBC with diff, again, you know, nothing significantly out of the range. This is his vitamin D level. With a patient like this, typically I like to see their vitamin D3, 25 hydroxy vitamin D3 level up around 80 to 100. And after seeing it at 31, we gave him 5,000 IUs of a Designs for Health vitamin D3 Supreme, and it has K1 and 2 in it, so that helps redirect the calcium from vessels to bone. And he bounced up pretty quick to 102. We held the vitamin D dose a couple months. It dropped back down to 50 the first part of this month, and so we reinstituted his therapy with just 5,000 once a day. We'll see where that goes. On 6/8, he had a number of labs. One of the challenges I was trying to deal with this gentleman on was his blood sugar, because we know it's not helpful in cancer. And what you can see is once we instituted, we really didn't do a whole lot with his diet, and I'll talk about that program, but we've done exceptionally well on dropping both his blood sugar numbers and his hemoglobin A1C down to 6.1, and it's been as high as above 9.2. This is his most recent lipid panel. Again, everything's kind of on the low side. His comprehensive metabolic panel, still everything is within normal range. Alk Phos is normal. His WBC with diff You guys can, again, it's really not remarkable. And there was a couple labs that were drawn and that I had asked for, which is just this progesterone and estradiol. So our clinic protocol, when we have someone that comes and wants to engage with either using cannabis for the treatment of symptoms while they're going through chemotherapy or immune therapy. And again, I caution with a few of the immunotherapies, cannabis is probably contraindicated. So make sure that you guys know what therapies are being used by the oncologist if you ever recommend the use of cannabis, because patients are coming from their friends and their family members, you know, trying to give them the best chance of survival and remission. And all of them are talking about the use of cannabis in some form or another, and they go to the oncologist or their doctor or their friends and ask them, what do I do? What do I use? You know, and that's how this patient came to our clinic. So we talk about lifestyle changes. We're trying to lower inflammation globally. We want to optimize the microbiome, and we want to try and avoid foods that are inflammatory or foods that they have sensitivities to, and improve glycemic control. We support, you know, exercise, mindfulness. I use a lot of subconscious reprogramming or retraining, visualization. We do a metabolic assessment and look at the different systems to see if there's something that they don't think is a problem. For instance, you know, bowel movements. Some of these people have a bowel movement every 7 days, 5 days, 3 days, and they think it's normal. And so we try and get them to have at least a couple bowel movements a day if they're eating more than once a day. We use the Microbiome Labs program. I've been using that for now about a year and working with Tom Bain, which is the founder and president of the company. He's a doctor of chiropractic professionally, and they're just doing some exceptionally great work, which is all evidence-based. And I'll tell you what, clinically, I'm blown away. Maybe I'll share some of the less dramatic cases with you on approaching just the impact of dealing with the microbiome and its impact on sleep, pain, and recovery. It's just remarkable with just doing that. So anyway, that's a big component of what I do. And we always consider cannabis. I think it's a helpful adaptogenic herb. It addresses so many different systems and problems. And as an adaptogen, it helps that patient move in a direction of homeostasis. And so what we started on, JR, we use kind of a modified Rick Simpson protocol, which generally talks about hitting a 600 milligram per day dosing. We use 600 to 800 as a treatment endpoint at a minimum. Take a 30-day or less, taper up to that dose of total cannabinoids per day, and then keep them at that level for at least 60 days, looking at whatever markers that we can look at, symptoms that we can look at, and determine whether a 1-to-1 ratio using multiple routes of administration and different cultivars, because we don't know which ones in combination are going to be more successful against the type of cancer that that patient is dealing with. Since we don't know, we don't have this, the lab that Mary has in Israel to be able to look specifically at that cancer cell type and see which cultivar it actually responds to. So we give it, our best guess and try multiple ways. If you can touch the cancer, you put cannabis on the cancer itself as well. So we approach it with trying to do that protocol. And then if things aren't going well, and there's evidence that says higher CBD ratios do better, like in glioblastoma multiforme, high CBD generally does a much better job than high THC. And then there's other cancers that just do better with less CBD or more CBD. So we go in either direction based on what we know and how the patient is responding. We taper them up starting with, we use the acid forms and the neutral forms of the cannabinoids. It's, again, since we don't know, that's how we approach it. Remember, CBD is the antidote to the intoxicating effect of THC or delta-9 in the neutral form. And so we can rescue someone that gets too intoxicated. And many times when we're using high dose therapy like this, 600 milligrams of cannabinoids in a day or more, and it's got a significant amount of THC in the neutral form, which again is the form that actually causes intoxication. It's actually the first metabolite, which is 11-hydroxy delta-9, which has much more intoxicating effects. And so depending on that person's cytochrome P450 system, they may have conversion quicker or slower, and that also results in different subjective responses to any of those therapies that we're using. So anyway, we start them low, we raise them up as quick as they can go comfortably. We give them tools to rescue themselves from intoxication, and we load them with CBD before we start adding THC, and the THC is always started at night. Suppositories have, for an equivalent neutral form or dose of THC, it's about a 30% intoxicating effect that you would get if you took that dose orally, same dose. So you get less intoxication from the suppository route, whether it's vaginal or rectal. And it also has not the same effect on appetite when you're giving RSO orally, which is an extract, generally an ethanol-based extraction. If you take that orally at a high dose, we have almost 100% of patients that are at 600 or higher milligrams orally, they have zero appetite. And for some patients, that's going to cause death because they lose weight, they can't eat. So the treatment that we got this JR on, in less than 30 days, he was able to taper up to the full therapeutic dose. And this guy's remarkable. never had no idea what his response was going to be because he had never been exposed to any, alcohol or anything else. And this guy just is not sensitive to the intoxicating effect of THC. And so he was able to taper the dose up. Again, we're using 300 milligrams, ultimately of a 1-to-1 RSO suppository. And he kept on doing the TID dosing of the taper up dosing. So this guy was on 900 milligrams rectally of a 1-to-1 ratio when I thought he was only on 600 milligrams. And he was taking this other stuff and still doing well. So the THCAA is the acidic form of Delta 9. We used a 6-to-4 ratio and started with 10 milligram capsules. So the acidic form, which all the cannabinoids are found in the plant, in the acidic form, decarboxylation or heat, light will also cause that conversion from the acidic to the neutral form. Again, the decarboxylation is that process. THC or Delta 9 acidic really doesn't cause intoxication. It does make people feel different. Most of the difference is a positive subjective response. So just to give you the rationale behind there, again, we're trying to use all different types of cannabinoids, both in their acidic and neutral forms. So we hope to find the right mix. We keep them on a buccal, an oral, a suppository, if we can, a topical. We make sure that they're on a microbiome treatment protocol, which is pretty substantial. Make sure their vitamin D's up, their essential fatty acids are in good shape. The receptors for cannabinoids are all essential fatty acid dependent. And sometimes when you find someone not responding to cannabis, whether it's CBD or it's other cannabinoids, take a look at their essential fatty acid status, omega-3. For the people who can't consume mass quantities because they don't have an appetite, vegetables, green, leafy, multicolor. We're looking for carbohydrate sources from vegetables, not from typically grains, and clearly not from processed foods, trying to eat stuff in its natural form. We can get some of these superfoods, greens, reds, and different types of protein, so you can avoid proteins that they're sensitive to, and they can drink this and keep their nutrition up. He takes magnesium because of leg cramps and other things, and so we kept him on that, as well as his other nutraceuticals. His current treatment as of the review on 6/10, we went back down because we weren't seeing any great results, unfortunately, on the current therapy. So we switched things up, lowered the suppository, again, changed the cultivar. So we're using a different cultivar than the previous couple months. We're using a different RSO. Ethanol extract, again, ethanol extracts versus other forms of extract using light hydrocarbon, which would be propane and or butane in different ratios, CO2, carbon dioxide, which is another extraction process that can either be subcritical or supercritical. Again, all of these different extraction methods for the same material will show a different cannabinoid, terpene, flavonoid, carotenoid, all the different components, lipids, ligands, there's over 500 physiologically active substances in a broad spectrum extract. So there's a lot of stuff that you just don't want to lose. So we've got this guy on this therapy. His C19-9 continues to increase. And so looking at the last number of 43,503 on 6/8, we decided to change things up on the 10th. So increasing the THC content, lowering the CBD content, we're going and raising delta 9 in its acidic and neutral form, and we'll see if the body responds to that. His PSA continues to increase, and so he personally wanted to hold off on the Lupron and see what happened. And since it continues to go up 15.58 most recently, he is deciding to restart the Lupron. His blood sugar continues to do better. We added berberine and alpha lipoic acid, and he just continues to do better. His insulin dosing today, instead of 44 of RNN, it's down to 22 or 23, something like that, units of each per day. So dramatic drop in his insulin requirement. He's doing, he just doesn't have complaints. He's got good energy. He does his 2 walks a day. He does have a nap. He doesn't have any GI symptoms. He doesn't have an appetite. And he gave me an example. He had a couple Omaha steaks, real high quality prime steak that he loves, and filet mignons. They barbecued them, and his son got to eat them all because he just had no appetite. But he can drink his nutrition if he can eat anything. His sleep is better, and his pain is still 0 out of 10. So this is his total daily dose of the acidic form of delta 9, neutral form, and CBD. And so, we started on the RSO orally. We're restarting the Lupron. We're continuing to improving glycemic control. I wonder whether renin-angiotensin system inhibition may be helpful for this guy. I know that we had a talk on it a month or 2 ago on our Tuesday talks. And so it's something I have no experience with using. Is there any other lab markers that would be helpful to follow? And, we've tried to get high dose vitamin C infusions in the Denver area for this guy, and we can't find a practitioner to do it for him. And so we're, open for any questions, suggestions, anything like that. And I'm using way more time than I thought I would. So we can either have talk about it or quickly go through Mev's case. Nev is a 60-year-old white female, works for the Nevada Farm Bureau, avid horseback rider, spent a lot of time sunbathing as well. She has a significant past medical history of hypertension. In 2010, in 16, she had the removal of a BRAF positive cutaneous melanoma with clear margins. And on 8/20, she had a bout of pancreatitis and a follow-up of her BRAF positive cancer, which returned and was metastatic at that point. She did have a younger brother die from melanoma, but there was no details that could be provided regarding that. And her chief complaints at the time that I saw her in January was chemotherapy-induced nausea and vomiting, a 9 out of 10, loss of appetite. She had 0 appetite, a lot of pain, very limited mobility. She needed a wheelchair and assistance. And just walking from the house to the driveway, she would almost pass out from exhaustion if she tried to do it without aid or a wheelchair. This is MEV, and this is the lesion that they left on her chest bone. So she was on Bertovi, Mektovi protocol, the amlodipine, oxycodone, some antiemetics. And when I had her referral, it was from a family friend that also is an expert in the analysis and runs an actual cannabis, ISO 17025 accredited cannabis lab in the state. And so they started her on this really low dose of a 1:5 CBD to THC ratio sublingual solution, oil-based solution, of which she took a 1/2 to 1 dropper full at night. And after the first dose, it like changed this gal's everything. You know, within 12 hours, there was a noticeable difference from family seeing her. She was able to start eating, and actually shortly thereafter, she was able to walk out to her car. Dramatic positive response. It took her a couple months after we talked to engage with me, and she said, you know what, Kent, I want to do a full court press and see if I can get a remission using cannabis. So we essentially went through the same protocol that we did with JR, although there was a lesion that we could see. So we started applying topical RSO to the lesion, and making sure that her vitamin D was up, her giving her essential fatty acids, and talking to her about lifestyle again and diet. So this is a picture on the left on 3/31 after 7 days of topical RSO. So it clearly changed its look. Ultimately, something fell off in between now and some of the other pictures, a portion of the lesion. The right side is the sacral coccyx area of this gal that a lot of necrotic tissue resulted from a radiation burn as they were trying to address some of the metastatic expansion that happened in her frame, and it just burned a hole right through her. So she was on a wound vac, antibiotics, and still is wrestling with that lesion. But before it got to that point, she actually was having a positive response from applying topical cannabis. It helped the pain a lot, and she felt way better. This is a picture on 4/20 of the lesion and also on 5/9. So it clearly looks different. They never did explain why they left the lesion on her and didn't remove it. I don't know how they make a decision there, but that's the two cases, and I'm wide open for any suggestions that you guys can share. Thanks.
Thank you, Dr. Corelli. Anybody have any suggestions, questions? And if Helps, no helps, nobody cares. Yes, okay, so NARS,
Hi.
fenbendazole.
Hello? Can you hear me?
Yes, we can.
Yes,
Jacqueline Mojo. I do homeopathy, and there's a medicine, a homeopathic medicine for the radiation burn that may help her heal. It's called radium.
Can you put that in the chat box so I can
Sure.
see it? Because your audio
The microphone is not
crackling
that
pretty
good.
bad.
Okay, okay, will do.
Thanks so much.
okay. Not your average everyday suggestion here, but okay. So Ken, do you have a future direction or
We're modifying the ratios, going towards high THC for JR, pancreatic cancer. I mean, the most pain he gets is like a sharp fleeting pain, a couple times a week in his upper right quadrant. There's really no spot he can put a finger on. His, there's just no tenderness that he can palpate. So he's just sitting there going, well, I feel okay. I'm not complaining about anything, Kent. I'm not sure what is working and what isn't. We're looking at crappy labs, but I sure don't feel what labs are supporting. And so let's just keep on going, forward and changing stuff up and seeing if we can do better. We will continue to drive that blood sugar hopefully down. And maybe we will luck out with some other, I would love to see him, get high dose vitamin C therapy. I mean, there's
nobody in the
ozone,
Denver area? You can't find anybody in the Denver area to do that?
No, I called all A4M, 13 people in the surrounding area. I didn't get one call back, not one.
Okay. Anybody knows anybody in the Denver area? Let us know.
Wait, join. Do you want to have video?
As far as Mev goes, she's got two daughters. One works as a professor at UNR, and they're frustrated with their mom because their mom constantly complains, but then doesn't follow the things that she needs to follow, especially her diet. And so if someone's going to, when they say, I'm gonna fight, I don't want to die, I want to keep living, and their actions don't support what they're saying, what can you do? And both her daughters are horribly frustrated because they see their mom doing a lot of stuff that they themselves know she shouldn't be doing. So I don't know how successful we're going to be with Mev.
We have a couple of other suggestions here. Another Greek test with the RGCC, that's the genetic test. That's Dr. Forsyth's test that he likes with IPT. Some homeopathic remedies here: radium, bromontium, 530C, 5 pellets daily for 10 days to 10 pellets weekly until healed. Plant-based diet with intermittent fasting for cancer. Dr. Ortel is asking about a vaccine. Is there a melanoma vaccine? I don't know about. High dose buffered oral vitamin C can help if the IV.
Now that's a good question, because there's a couple protocols that I've used in the past. I can't remember the doc's name, one of them, but dosing to get a really good bowel cleanse, a GI dump, you know, where you're cleaning top to bottom. You can use buffered vitamin C dosing every 30 minutes until, you know, you not necessarily explosive, but clearly, you know, watery diarrhea, you know, as an endpoint. That works pretty well, because it causes both motility changes as well as an osmotic change. But I was told that you can't get up to that 350 nanogram per mil blood level or higher orally. You can never get to the point where vitamin C is making hydrogen peroxide within the cell, you know, to kill things. That's how I was taught. And I haven't seen any evidence to say that you can do it orally and get anywhere near that number. Does anyone know that?
Dr. Ortel again says vitamin C rectally to get the higher value.
Thank you. Never done it.
You'd have to use the buffered.
That's for sure.
Okay, so we went a little bit further, longer than I thought we would. If you're all willing to hang in, thank you, Ken. Anybody else has any other comments, please put them in the chat, and we'll share it with everybody. This is being recorded, and it will be up on our website. I'll give you the link again before we leave, because I am up next. So Ken, any other comments? Questions?
Just putting in my email address in the comment section. Oops, that one to direct. Let me do it to everyone.
Okay, and
Thank you guys.
thank
Appreciate it.
you. Thank you so much. Okay, so my case is extremely interesting, and we have a guest with us. We actually have Svetlana with us. So I am going to unmute her so she can jump in and comment, if that's okay with everybody. Before I even begin, Svetlana, I'm going to apologize, because I changed some of the history here, because I don't like to. This was before we got together and spoke about that you would be on the call with us. So I changed some of the background history and whatnot. It was just to shield, you know, so that you wouldn't be able to be identified at all. So if you see things in here like you have thyroid disease, that's just kind of my my way of keeping things, you know, sort of anonymous. Okay, so don't get excited. Don't get excited about all this stuff. So okay, a couple other things that you'll correct me on it, so that I'll you know, I'll get it right for the next time. So so on the line with us is Svetlana, and she lives in Walnut Creek, California, which is approximately, I don't know, about 3 to 4 hours away from Reno, where I am. And she's 39 years old, and she is from Eastern Europe. And she had a not very long history of all of these symptoms: burning skin pain, major depression, brain fog, poor concentration, cognitive issues, memory loss. She had pain, floating pains from head to toe, constant ringing in the ears, muscle cramps, dry eyes, pins and needles. In the Chinese medicine, and please, I said this to somebody once a long time ago, and they thought I was calling them dirty. It's not. In PCM, it's known as the running piglet syndrome. It's like sort of like little nails running up and down your arms and legs. Sort of like paresthesia. Skin crawling is what it is. Boring knife-like bone pain, and always feeling like there's a glove or a glove on her hand, or a sock on her foot. These were the symptoms, and she'd been to many doctors. And so this is some of the stuff I made up. You can tell us where you really came from. I actually didn't have this information. I know it was Eastern Europe. I had your birth date there. So this town, Yelskins in Belarus, is in the second zone downwind from Chernobyl. So I gave her thyroidectomy, and she did have ulnar nerve surgery at age 32. She did not smoke, a rare alcohol, and no history of drug use. Family history: her grandmother had breast cancer, grandfather lung cancer, mother heart disease, palpitations, and a sister with hypothyroidism. Her medications: allergies to penicillin. Medications: she was taking Celexa, 40 milligrams, fluvoxamine, CR, which is another antidepressant, venlafaxine, which if those of you who know me know that's my favorite. That's sarcastic. I hate it. Mirtazapine, 15 milligrams once a day. That's Remeron. Doxepin, gabapentin, and levothyroxine, 88 micrograms once a day. A master's degree in education, and she was a financial advisor. And again, like I said, I kind of masked some of your real information, so because I don't want anybody to able to identify it. Unable to be employed at the moment. Symptoms began about 3 to 4 years ago. Breast tenderness, left lower quadrant abdominal pain, heavy menses, fatty food intolerance with delayed postprandial right upper quadrant abdominal pain. She had an ultrasound of the pelvis. She was found to have a mass on her left ovary and with some bony tissue in it. The diagnosis at the time was a dermoid cyst with endometriosis and cholecystitis. She had heavy vaginal bleeding in May of 2017, and her blood count went down to 9.8. CAT scan was inconclusive. She had an MRI with IV contrast, which showed endometrial thickening and the bizarre left ovarian cyst with bone and hair in it. It was recommended a hysterectomy. She had first refused. The next cycle, there was a repeat of the heavy bleeding with clots, and she sought another opinion. She went to another medical center. They had a repeat MRI with contrast, and she had similar results with blood clots and left hip pain on ambulating 24 hours after the MRI. Anybody in the chat room have any thoughts at the moment here? So, okay. Okay, in 2017, she had a family crisis, and she went back to the old country to care for her mother, who passed away in August of 2017. She returned to her original OBGYN as the symptoms continued. We had a third MRI with contrast was ordered to determine the changes from the original changes. The dermoid cyst was slightly larger, and endometrial was thickened at 14 millimeters. She had a hysterectomy and bilateral salpingo-oophorectomy in September of 2017. Since then, she's been complaining of severe pain, she could not tolerate touching of her skin. And she had to sleep with the sheets off, and she had burning sensation of her lower extremities. Post-op, she began having headaches and lightning bolt migraines, visual clouding, shortness of breath, muscle contractions, and she was overall weak, and she was managed with opioid narcotics and gabapentin. 4 weeks post-op, she had no change. There should be no changes in signs and symptoms, and she began experiencing hot flashes and night sweats. Okay. she's seen a lot of doctors, and these are the diagnoses that I actually have in my chart. You know, from everything that I've been able to gather. I'm assuming that probably there's even more. I'm not going to read them all, but you can see things like systemic connective tissue disorder, memory loss, attention deficit disorder, general sweating, constipation, hyperlipidemia, low blood pressure, anxiety. Please mute yourself, who's ever talking. And let's see who's. Okay, we good now? Okay. So we have lots of diagnoses, lots of doctors. Physical exam, she was 5'3", 146 pounds. What's going on? No temperature, scar on her right elbow from the left ulnar nerve pain. She had some reddening of the calves and shins, thickened discoloration in skin in her ankles, knees, and wrists. The Beck Depression Scale was positive. The general anxiety depression, general anxiety scale was also moderately positive. This should be a moderate anxiety, not depression. Okay. So we did a neurotransmitter test, urinary neurotransmitter test. We came up with an elevation in epinephrine and low in histamine and low in serotonin, which is probably not a big surprise. Irregular laboratories, get that out of there. Our vitamin D was low at 24.6. Testosterone was at 28. Our goal is 30 to 40 there. The PD ratio was 174, which is actually nicely balanced. Her TSH was 3.44, T3 3.2. This is normal, but a little bit on the low side. Reverse T3, which we use as a proxy for cortisol or stress hormone, is positive in our view at over 15. It was 10. And IGF-1 as a proxy for growth hormone was 233. Hematocrit was a little bit low. MCV, which we use for cell size, B12 and folic acid, if it's over 98 is 91. Pregnenolone was a marker for memory. Goal is 90 to 110 was 76, which is actually pretty good. And her inflammatory markers were okay. Again, I got that neurotransmitter test out of order, but she had low serotonin, high epinephrine, low histamine, and a lot of that goes along with the symptoms that she was talking about. Mood concerns, sleep quality disorders, associated fatigue, and digestion, appetite control, drowsiness, moderately and causes drowsiness. Low histamine. Usually you would be expecting high histamine. We added some pregnenolone. That's for her memory. That's a long-term deal. This is not an overnight thing. She's not going to be speaking Portuguese the next day, but it takes about 6 months before we get an effect here, but it is quite effective. We added a little bit of zinc, again, for a number of reasons. That zinc will increase your testosterone level slightly. It will lower your estrogen levels slightly. It's a bit of an aromatase inhibitor, and it has all of the properties that we've been talking about for weeks on end. Against the viral cytokines. Vitamin D, we started her on 5,000 units at bedtime, and we gave her a little bit of GABA for her anxiety and panic attack. These were the recommendations, and we sort of bunched them together that we put together. So fermented foods, dairy products, dried fruits, avocados, eggplant, spinach. We gave her rhodiola, some L-theanine, and some SAM-E. We didn't really get a whole lot, very far. Our next step was we did a micronutrient test. This one's from Genova, and we came up with slightly their micronutrients were slightly low, not terrible. A little bit low in magnesium, digestive enzymes, and also manganese. And the amino acids, there a couple of them were low, so we added some supplements there. However, we did a heavy metal test, and look at this here. And this was a big surprise. This is and I called Svetlana. I told her I have no experience with this. I had to go look this up myself. And so, if anybody in the group have any experience with this, you can, shout out, let us know. So gadolinium is what is in the IV contrast dye for MRIs, and she had 3 MRIs in several months before all of these symptoms started. And so we sought out a couple of experts here, and how many of us say, order an MRI and say you'll get a call? Do they want it with or without contrast? Well, it's better with contrast. So how many of us think about it? I don't know how many in our group have even run into anything like this. So heavy metal toxicity symptoms are chronic fatigue, brain fog, mood swings, depression, anxiety, chronic exotic infection, fungal infections, parasites, GI complaints, microbiome, like Kent was talking about, vertigo, migraine headaches, visual disturbances. And I put this list next to Svetlana's complaints. And you can see, we got a lot going on here. So gadolinium, I had to go look it up. It's a tiny white metal. It has atomic number 64. It's a rare earth metal. It's in the F block on the periodic table, if you can remember back that far. And it's used for contrast material to distinguish abnormal structures on MRI scans. By itself, it's toxic, but it's usually attached to a chelating agent, which is supposed to render the gadolinium harmless. Now, there have been over 400 million IV contrast exams done with different types of gadolinium. There were 8 types, 8 different varieties up until about 2 years ago. The one was taken off the market. It was found in 2007 that renally impaired patients who have IV contrast are exposed to an exceptionally pro-inflammatory state, and they get this scleromyxedema, like cutaneous disease. I'll show you a picture of that in a minute. So gadolinium is contraindicated in patients with GFRs of less than 30. And if it's accidentally given to someone with a renally impaired, immediate hemodialysis or initiating hemodialysis actually may not actually protect against what the issue for the renally impaired patients were, which is nephrogenic systemic sclerosis. Now, again, 8.8 million gadolinium enhanced procedures were done in 2016. The indications for it are, what it does is it detects inflammation and increased blood flow. Brain injuries, spinal cord injuries, I don't need to let everybody here know this. Inflammatory bowel disease, inflammatory joint disease, some types of angiograms, blood vessel issues, solid organ, such as liver and kidney inflammation. So here's the case for IV contrast with gadolinium. Here's a MRI of the brain, and as you can see, we can see it easily now with the IV contrast. Here's another one, and as you can see, there's a little area of decolored there. As you can see, so it is quite useful for finding structures that are really very subtle and difficult to find. There's 2 main types of gadolinium. There's the linear, it's an open chain, and these are the brands here. This Optimark was discontinued. and there's 2.5 times. The issue is that gadolinium gets deposited in cells versus first it's deposited in the cells, and you get 2.5 times as much gadolinium deposited in cells in these linear or open chain chelating agent versus the macrocyclic, which is a sort of a closed chain and allows the gadolinium to do what it needs to do, but it's more protective. Package insert, it states that side effects are headaches, nausea, dizziness, injection site pain, altered taste, and a warm feeling. It's listed rated 0.7 to 2.4%. And it states that 90% of the gadolinium is excreted in a renally intact patient within 24 hours. Nephrogenic systemic fibrosis is the issue with the renally impaired patients. Predisposing factors was using a linear, non-ionic, less stable gadolinium ion substance, especially in chronic stage 5 chronic renal failure. It largely disappeared after 2007 when the Magnavest, which was an ionic linear agent, was withdrawn from renal patients. And the mean onset from time of exposure was 11.5 days, and it can develop within 24 hours and usually up to 2 weeks. The skin lesions are here. You see it. I have a picture of it. It's called Poer, and it's erythematous, and it's associated with induration and edema. They're usually bilateral and not on the face, but on the extremities and the trunk, and we can get joint contractures. If you do a biopsy, you'll get CD3, CD34 plus fibrocytes are stimulated and released in the settings of chronic inflammation. The patients end up with respiratory failure and internal organ involvement, and the mortality rate is listed as 31%. So it's not something to be around with. So in the late 2000s and early 2010s, the reports came that patients that were renally intact were exhibiting some of the same symptoms. Following IV contrast, it appears that gadolinium will leave behind some residue in the bones, the brain, and the kidney. And the residue left behind with an intact blood-brain barrier and preserved renal function is termed a gadolinium deposition disorder. There's a main set of symptoms, like A symptoms and B symptoms. The A symptoms are brain fog, head pain, dry eye syndrome, muscle fasciculations, or running piglet syndrome, the pins and needles. Sine qua non is burning skin pain, even with normal looking skin. You can have thickening and skin discoloration and a metallic sensation in taste, smell, and overall body odor. B symptoms are cardiac arrhythmias, GI symptoms, tinnitus, loss of balance, depression, and hair loss and loss and tooth loss. I have a little skeleton here. So we'll put this up on our website. If you want to, you can just get a picture of this. And the black lettering is our primary symptoms, and the red are the secondary. And so here are the symptoms of gadolinium deposition disorder, and here's our friend Svetlana. And again, you can see they overlap almost word for word. Svetlana, are you there? Do you have anything you want to add? I'm going to get into the technical aspects. If you're there, we can get you unmuted here. Was here. Anyway, I don't see her now. Okay. So again, those of you who heard my talk on finasteride, remember that there's a lot of hue and cry when it first came out that there were symptoms of mass hysteria, and that it wasn't anything real. It seems that the gadolinium chelating ions are associated with a high signal intensity on unenhanced T1 weighted images in the dentate nucleus and the globus pallidus in the cerebellum. And so if we look at the location and function of where the gadolinium is deposited, we can see, we can actually match it to the symptoms that the patients complain about. So in the dentate nucleus, which is deep in the white matter of each half of the cerebellum, its function is for planning, initiation, and control of voluntary movement. The dorsal region of the dentate nucleus is for skeletal muscle function, and the ventral nucleus is for conscious thought and language and cognition. Here we have our brain fog and our lack of concentration. The dentate nucleus houses Purkinje fibers, which, oh, she's back. You're back. You can unmute yourself, or we can unmute you. We were asking if you had anything to add at the moment. You can unmute yourself, Svetlana. If you have anything to add or wish to share with us, please do.
Sorry, Dr. Clearfield. I'm in a car and the connection was lost, so I missed out on some of the information.
Okay. Well, I hope I'm not embarrassing you too much here.
No, not too much.
Okay. If I don't embarrass you a little bit, then there's no use getting out of bed in the morning. So is there anything you'd like to add or correct as far as symptoms, how this all develops? We haven't gotten to where we're going yet, so. Or you can
just trying to decide the best approach for this and the best type of treatment. And this is where I'm currently am.
Okay.
Point.
Okay. And we're having a hard time hearing you. So I'll tell you what, send me the particulars, email me later, and I'll share it with the group. Okay, because kind of meet you, kind of tinny. Okay, so again, the dentate nucleus is the site of visuospatial language, cognition, skeletal muscle function. It houses the Purkinje fibers, which are GABAergic, and it's the inhibiting neurotransmitter. When we lose this, we get agitation, irritability, and those kinds of symptoms. Medical maladies that are associated with dentate nucleus injury are cerebral ataxia, maple syrup syndrome, Alzheimer's disease, autism, and essential tremor. The globus pallidus is in the basal ganglia, and it regulates voluntary movement. And it again is inhibitory. It balances the cerebellum. It kind of fine tunes movement. So again, if we use our imagination and connect the dots, you can see that a damage, we put something in the globus pallidus and the dentate nucleus that doesn't belong there, we're going to lose our inhibitory neurotransmitters, which again is GABA. And medical maladies here are motor dysfunction and Parkinson's disease. Okay. This is an MRI series of a patient with this was on autopsy, was found to have gadolinium deposited in their dentate nucleus. And if you go back, you'll see that these little white structures, which seem to be growing over time. So I just wanted to use that as a visual for that. Okay, disorders of metabolism associated with gadolinium deposition: calcium channel blockade, inhibition of mitochondrial function, induction of oxidative stress, and inhibition of calcium activated enzymes. But when you see this list of issues that are associated with gadolinium, I hope we're starting to think about how we're going to how we can help reverse some of this. Inflammatory markers and that are changed with gadolinium deposition. Interleukins 2 and 6, interferon gamma, TNF alpha, and TGF beta. Also, interleukin 4. Here we are, TGF beta again, interleukin 13, and VEGF. Other cytokines are here, and that got me to thinking. Those of you who know me, these are the 4 areas that I've sort of been studying over the last several years. We spent a lot of time on traumatic brain injury. We spent the last 2 years doing a lot of study on autism and autistic kids. And what we found is that these are the cytokines that are disrupted in autism. IGF-BP1 is a growth hormone transporter. Interleukin 1B, interleukin 6, CCL2. And then here's gadolinium, and here we are again. Interleukin 6, interferon gamma, TNF alpha, and then these other cytokines. And then our post-finasteride syndrome, again, interleukin 6, interleukin 1B. So you can see that the symptoms overlap, and you can see that the inflammatory markers also overlap on all of these maladies. Here are the references for all the last few slides I gave you. I couldn't get them all together, so I gave you the references here. So Svetlana went to Stanford, and they didn't like our test, so they did their own. And lo and behold, look what we have here. And they told her that this was normal. She did not have gadolinium deposition or excess gadolinium. So how do we reconcile the fact that gadolinium here is off the chart and the gadolinium here is normal? Anybody in the chat have anything to say about it?
Can you repeat the question?
Okay. Well, the question is, Svetlana went to Stanford, and they did this gadolinium test, which came back as normal. So how do we reconcile this test from this test?
Yeah, it could be lab errors, right? So I'll do a third lab test to just reconcile both.
Okay, here you go.
Didn't buffer it or I put it in the wrong, you used the wrong type of container to collect the urine.
Well,
Did you treat them and then sending the other sample? Because if you
No.
treat them, then
no,
okay.
has not been
So
treated
it's a
at all.
lab. It's really all this lab discrepancy. It happened because of lab errors. Then when you get 2 labs different, just go ahead. We'll do another third. And
Here's a third
will give
lab.
you
Here's
the-
a third test. We just got this actually last night. Here's a third test from another lab.
And it's in favor of what?
What do you see here?
The third test is in favor of the first lab or the other lab.
Well,
Go with the third lab.
this is the third
Especially if it's
lab.
confirming one of them.
Well, here's your
Okay, and the
reference
third-
range, and here's your result. It's double. And I don't know what this green means, because this is wrong. It's not right at all. So the difference is in the Stanford test, the reference range is higher than the reference range from the Genova test. And the issue is that the Genova test is much more specific and much more sensitive. And the Stanford people told us that that didn't matter. Well, I think it does matter. We have somebody who's had all of these symptoms for all of these years that match symptoms of this issue. We have an extremely positive test. Now we have this one here, which also shows a double the reference range. Again, I don't know I don't get what this is here. Maybe somebody can explain this to me. but we have double the reference range right here. And, you know, like I put in the thing that, you know, the big boys just don't like us. You know, they don't want to hear about any of this. So here are
Did
recommendations.
you did the CBC differential for those people?
Yeah, and you know, her CBC was fine. You know, they're
And
inadequate.
differential. There
Yeah.
was no neutrophilia.
Yeah, no.
Okay.
Okay. So so here are the recommendations that we've had so far. She's had very little as far as intervention, and you know, so far in this you know, in you know, with what we've found so far. So we've you know, we've recommended the autoimmune diet for her, and even with an elimination. And I just listed all of the things here. I'm not going to read them off. Most of us know them, but if you don't, you'll have them here. And this is what's not allowed. Of course, no gluten, no grains, no legumes, no dairy, no sugar, no alcohol. Okay. The treatment of choice is IV chelation, and it's IV chelation with DTPA, which is 300,000 times more stable than EDTA, which is, you know, the one that we usually think about. And the stability is the key to removing the gadolinium without disturbing it in the body. The issue is when you do this type of chelation with gadolinium, it will move it from where it's deposited into the bloodstream, and the patients get what is known as a flare reaction, sort of like a Herxheimer reaction. It can be quite severe. The goal is to remove as much as the gadolinium as you can without getting it redeposited someplace else. Since DTPA is 300,000 times more stable, it will hold the gadolinium and remove it more of it from the body than the EDTA. And the redistribution rate is 1% for DTPA versus 30% for EDTA. EDTA is more readily accessible, however. If you don't get this flare reaction, then you don't have gadolinium deposition. The treatment schedule is you do it 2 days in a row, usually with a calcium ion attached to the DTPA on day 1 and zinc on day 2, and you do it every 4 weeks after that. You continue it anywhere from 3 months to a year. The idea is for the patient to be 80% improved. Can get pre and post gadolinium urine levels. However, so far, and the experts that I've talked to said that they're never sure that the gadolinium has been completely removed. Here's the protocol here. It's a sum total of 1 gram of DTPA. It's an IV push with 90 minutes of saline as a chaser, and that's how it's done. And you repeat it anywhere from 5 to 15 times, approximately once per week. The thing the patients don't like is they get this hypersensitivity reaction, and the medical personnel, the radiologists who are doing this, will use prednisone, will use the radiology hypersensitivity protocol, and a Medrol dose pack. And they'll also use some Benadryl with it. So I went back and I looked at the cytokines that are involved, and then I looked at some remedies that we've gone over, you know, in the past that involve, you know, neutralizing these remedies. And the one that I came up with that would work the best would be low-dose naltrexone. And because low-dose naltrexone, it has activity against all of these cytokines. Quercetin, rutin, and luteolin are also good choices. And there is a commercial product called Neuroprotect. I think I have it in the next slide. That is a combination of these 3. And the dose here is 1 capsule per 10 kilograms of weight. So if you weigh 50 kilograms, if you're 122 pounds, you would use 5 capsules a day. You would use this for approximately 6 months. Omega-3 fatty acids and resveratrol also have activity against these cytokines that are stirred up in the flare reaction, and also N-acetylcysteine, but as we all, and nicotine, but as we know, N-acetylcysteine is sort of in limbo right now. Here are the references for that. Other medications, if you're so inclined and not of the usually supplement ilk, for interleukin-2, we have metformin, cyclosporine, and tacrolimus. For interleukin-6, testosterone, verapamil, bumetamide, and low-dose naltrexone. TNF-alpha, spironolactone, low-dose naltrexone, spearmint tea, and one of the biologics. And there was interleukin-18 there, and I found a reference using culture. This is the ingredients for that Neuroprotect, and it's available online. You can get these, separately, of course, but this is one capsule. It's kind of expensive. It's about $40 for a month's worth. These are Mark Gordon's products for his traumatic brain injury, and these are the ones that will, again, these are combinations, and these will, have adequate activity against the cytokines that we're looking at. And that's it. I don't know if Svetlana's still on the line, if we can hear from her. If not, a bunch of stuff in the chat.
I will add losartan will help because it does have a very strong antifibrotic effect to the regimen. You already add NAC, N-acetylcysteine, right, to the regimen.
N-acetylcysteine, yeah. Mm-hmm.
Yeah, IV losartan will be the second, and you already did polyphenols, which is curcumin and quercetrine and all those resveratrol, all that good stuff that help. And I see the shift is going to TH17, TH1, especially TH17.
Mm-hmm.
So you are giving medication, low dose naltrexone, to polarize the immune system back into Treg and TH2. So yeah, I think your regimen is clearly very good. I like it.
So I thought this was a really good case. It wasn't anything that was on my radar. We're kind of proud of ourselves here that we were able to find something that's Stanford, and I think she'd also been at UCSF. They missed it also. They basically told her to go home and take antidepressants. Was she's exposed to radiation at Chernobyl? The answer is I don't know. She is hypothyroid, and it is in her family, and they were in the area. She was probably about 4 years old when Chernobyl went off. Dr. Rortel, I had a patient with this toxicity and symptoms after MRI. So, and Dr. Molijo. So one of the points is that we've ordered, all of us have ordered. Well, it depends on how long you've been around. I've been around, since Methuselah was born. MRIs didn't exist, and the question is, we get these calls. You want it with or without contrast? We'll without thinking, we'll say, well, we'll just blow it off, and say, well, okay, it's 0.7%. Well, 0.7% of 400 million studies is quite a large number of patients. Something about Naples, Florida. We're trying to bring your style here. Okay, that's Joe Ballard. Okay, Joe, I'll talk to you later. How are these are urine tests. If you were asking about how the gadolinium tests were done, those are urine tests. These were not challenge tests, so we did not do that. These were unchallenged tests that were done. Okay, and no, she had 3. Is this just one session of use of gadolinium? She had 3 MRIs in the 2 months, all without IV contrast, the IV contrast before the symptoms began. What type of line test was done? It was in the urine. I think it was in the urine test there. I'll have to look that one up. I'm not sure. Can it have accumulated over time? And rather than just an MRI? Well, the answer is yes, but I don't think we'll ever know because you know, the symptoms, she didn't have any of the symptoms until after these MRIs. And we didn't really relate the symptoms to the MRI, the IV contrast until we got this, you know, this test came up. DTPA is available from an outfit called I'll get it to you. I don't have it off the top of my head. There's a Dr. Richard Semelka. He's kind of the guru of this. He's a radiologist in North Carolina. You can look his name up, and he's the guru on this. Okay. At the moment, the patient, she's been looking for natural chelation. She's kind of afraid about the flare reaction. So
What about what those natural ones, activated charcoal and zeolite? Do you think it will work?
Zeolite is pretty weak when it comes to this. You need something that's going to pick up and hold the gadolinium. And so I don't know. I'd have to look into whether that would be
just an extra. I'm not saying a replacement of EDA.
Well, the danger is that the danger here is that any chelating agent is going to move the gadolinium, but you want to make sure that it doesn't. It's strong enough that it will remove as much as it can from the body and not redeposit it someplace else. Okay.
What about combining? Like I'm saying, let's do the IDTI, and then at home they start taking zeolite. So it's an adjunct. It's not the main treatment or replacement.
I think that's probably the way we're going to go, but we really haven't gotten there yet. So
I had patients. They have renal impairment, and this, well, it was a mistake that the doctor ordered MRI with contrast. And
well, the radiology department is also responsible, and they have to know, you know, they have to know what the renal function.
She died completely renal after that contrast injection.
Yeah. I mean,
everything.
You know, even if I order an MRI with contrast, I mean, the radiologist, you know, is also responsible and needs to know what their renal function is, and if it's you know somewhat anywhere there, you really should not use. They shouldn't use this stuff.
Don't you think people taking anti-inflammatory drugs not to do contrast because they're more high risk? What do you think?
I don't know. I hadn't thought about it. Anybody else have any thought on it? So, I mean, most of these folks.
Somebody is on NSAID or steroids.
I mean, most of these.
You think they have to be stopped for a while, like maybe a week.
I'll have to go back. I'll have to go back and look at what the protocols are. I'm sure these radiologists must have protocols for this. For that, I mean, most of the patients are on some of these medications. I mean, why are they getting the MRIs in the first place? Not doing it just for fun.
A great case. So you're gonna present this in and Thursday for sure, because this case is beautiful, great.
That was my.
I like this case.
Not this Thursday. I am traveling to Miami to see the grandkids, and
oh no, not necessarily this Thursday. When you have time. I know it's very difficult for you to hold on here. When you have time.
And you all get to be without me next Tuesday because I will be.
I have Dr. Joseph. He's going to present a very beautiful case.
Dr. Halasi, you have to be
COVID-19 fibrosis.
You're gonna have to be the lead here because I will be flying during our time together, and I'll try to get an internet connection on the plane, but I can't guarantee it. So,
I need to have an osteopathic doctor on my side. So John Berger, are you there? He can be the
we have Dr. Dalton's here, Dr. Stoker's here, Dr. Dalton, Dr. Chen. We're all osteopaths here. Dr. Andrico.
Right. I need to have some representative. So I got Dr. John Berger. He's become my buddy now.
Yeah, we're gonna make you an honorary osteopath. Okay, so
John Berger, I'll be here next week. Thank you.
Okay, So any other comments, anything else in the chats? I don't see anything. Again, let myself or Dr. Burgess know if you're interested in presenting anything at OMID. You know, we're going to have sometime in July, we're going to have to turn in a preliminary schedule. Again, if you're start out slow, we started the last time we did a live show, we started out slow. We had about 60 people in our room. By the time we were done, the count was over 600. And there's 3,000 to 5,000 doctors there. So not bad for, you know, a tiny minor subspecialty. I'm shooting for our name change before OMED so we can you know, advertise ourselves as integrative medicine, and pushing, but it's not number one on their agenda. So anybody have any other questions, comments?
I have a comment.
Yes.
You know, her Svetlana's vitamin D was super low. It was around, I
Yes.
think you presented, it was 26.
Yes.
And you currently have her on 5,000. Have you checked her recent vitamin D? And would you think about like using vitamin D as a detox agent for the gadolinium? Because I think vitamin D, along with I think estrogen as well, act as detox agents in our bodies. So since
Um,
with the metal toxicity, I think it helps with metal toxicity, also with metal movements as well. So if we're able to increase the vitamin D levels at some point, will it be stabilized enough to
yeah, we
assist in the movement of the gadolinium in a stable form outside the body?
yeah, we usually do labs every 4 months when we see them that low. On average, I don't have it off the top of my head. I can, you know, go check my notes. Or if Svetlana is on, you can, if you remember what it was, you can let us know. So on average, for every 1,000 units of vitamin D, D3, it should increase our 25 hydroxy vitamin D level by about 8 points. It takes anywhere from 2 to 3 months. So her 26, as she's at 26, 5,000 units times 8 is 40, and the 26. So we should be in the 70s range within 2 to 3 months. You know, that's if she uses a high quality vitamin D and if she uses it every day. We'll sometimes use the pharmaceutical 150,000 once a week, which will give us a comparable you know, result. But what her repeat level is, I don't have it off the top of my head. I'll look it up for you and let you know later. And the other part of the other question was, can we use vitamin D as a metal detox agent? The answer is yes, but I've not seen any literature matching vitamin D to the gadolinium in the realm of either detox or chemo.
Okay, thank you.
That answers it.
Yeah, as best as I can data for now.
Okay. Somebody asked what the mold test was done. The mold, it was that was a LabCorp. You know, I think it was an IGM LabCorp test. And it says to keep you informed about Svetlana, and we will certainly do that. Dr. Halassa says that losartan can lower TGF beta 1. I'll add that to the list. Any other comments, questions? We will have this on, we have this recorded. We'll have it up on our website. Let me put the address in. It's AOS.
Yeah, I tried to get the videos. I don't know how to access it. Do I have to have a password username to get into your website?
Not for the webinars. You need it for the last our last seminar. If you were a paid member, we'll give you the password on it. We usually, our seminars that patients that the doctors, pay for, and we get give CME credits for. We usually password protect those for about a year.
What
So
about my lecture, the last one that I have with Dr. Patel?
if it was on the Tuesday night ones, I put them up as as soon as I get them rendered and sent to our our web person. So if there's ones missing, let me know. And
Yeah, the one that Dr. Patel and I cannot figure it out. Is
if
there any
you
way you can send me that link?
if you let me know what the date is, the link is right.
It was last week, maybe, or the week after. It was last week, yeah. The last week.
That one I sent up on Thursday. I'll check on that. Here's the link, aosd.org/webinar, and they go from the latest to the earliest. All the ones that were there. Some of them have recordings, some of them don't. But they all have the slideshows. And if you look through it, you're going to see we have we're accumulating quite a collection of academic.
Yeah, I see it now. I see it. Okay, great, beautiful.
Okay, so
thank you.
Okay, we have Dr. Kathleen O'Neill Smith with her immunology. We have Dr. Lavelle is there, Dr. Gresh. You don't know who these folks are. These are some of the really heavy hitters of in the at A4M and AMMG. The two of the main anti-aging medical groups. These folks get a lot of money to speak for an hour, and we've gotten them for free. Coming up next month, we have Dr. Pam Smith, who is actually the originator. She was the originator of the A4M hormone program, and so we have her coming up next month. Dr. Halasi, we have somebody for next week.
Yeah, we have
Joseph.
We have Dr. Joseph.
Okay.
He's going to talk about post-COVID-19 heart failure, stroke, and vascular fibrosis. He has a very interesting case. Very well.
Okay, and those of you who are on with Dr. Ethel, I guess he had a rather bad reaction to the vaccine, so be careful out there. Okay, any questions, comments, complaints? If not, we're going to say good night. And like I said, I will try to get here next week. It's kind of iffy, so if not, I'll see you all in 2 weeks. Thank you all for participating. Svetlana, if you're on, thank you so much. If you're not, I'll get in touch with you later. And folks who are new here, thank you for coming. I hope this was informative. Bring a friend or two or six so we can grow our group. Anybody who's interested in presenting anything, please let us know. And so I'm going to say
do you have incentive for bringing doctors the same way they do for vaccine? $1 million lottery.
Yeah, we're gonna have a lottery. The winner gets our next conference for free, and if you come in second place, you get 2 conferences for free.
That's funny.
Right. So, okay. Thank you all. Yep.
One question.
Yes.
It's Ken Andronico. When you were talking about the vitamin D, as far as application of the vitamin D, probably behoove you to, if you're going to give it PO, to give it with calcium citrate, so it gets in the GI tract. Otherwise, it won't go into the system and get metabolized by the liver. That's one thing. The other thing might be good as well, as to give it IM, 50,000 units IM in their butt. Okay, because I have seen the numbers go up quickly with my patients that I've given them on a bi-weekly basis when they come in for hormones or otherwise.
Okay.
Just want, for whatever that's worth, I wanted to add that.
Okay.
Yeah, let me add something to that too. Very important to fix the carotenoid level, because if you have deficiency of carotenoid and you give them more vitamin D, will not be absorbed. So carotenoid is very important. that needs to be fixed, and then you give them vitamin D. Also, you need to give them some vitamin K to prevent the calcium from depositing into the tissues
I
as
agree.
well.
Yep.
And I think the best source of combination of all of that is cod liver oil. I know it tastes nasty, but you know, it's way better than the capsules in absorption.
Well, if we can't give somebody something nasty, then we haven't done our job. You know that. If we can't make somebody miserable once a day, well, what's the point of getting out of bed? So, okay, we will take those recommendations to heart. Anybody else? Thank you, Ken. Anybody else? If you have, like I said, friends, colleagues, please bring one person. Let them know. Share the link is the same every week. The ones that we send you for the Zoom conference. Please share it with somebody so we can grow our group. And I thank you all again for being here. On quite a bit longer than I thought we would be. And I'm going to say good night for now.